Domenico, good day, good afternoon. You are welcome to our RITA seminar concerning non-traditional, non-invasive methods of CPAP therapy outside ICU and inside ICU in COVID-19.
Good afternoon to everybody. Thanks for the invitation. And I'm delighted to join you to show our data and discuss these important issues. Thanks a lot for the invitation again.
I'd like to say that thank you for your consent to participate. I'd like to say that Dr. Domenico Luca Grieco is the headliner of the first and until recently the only study concerning randomized control trial concerning comparison between non-invasive ventilation and high flow oxygen in COVID-19. Am I right?
Yes, we ran the first study and now we have got some new data, but concerning specifically the helmet interface, the random trial. So
okay.
we'll discuss in details this in my presentation after.
And so I introduce your lecture, which will be non-invasive helmet ventilation versus high flow oxygen for COVID-19. An overview of HENIVOT study and what is not included in this study. Please.
Okay, so I will start answering that. I think all the data we had, those are included in the studies. So I will try to show the rationale and also the perspectives after the end of the trial. I will show my slides. Please confirm that you can see them. So thanks again for the invitation. I'm delighted to join you. And I will try briefly mention some historic with some brief history. And so the role of NIV in acute hypoxemic respiratory failure is an old story. We know from guidelines and a lot of randomized
Domenico,
trials
please, sorry.
NIV.
Can you make some pauses because of translation? Yeah? Sorry.
So we know that from guidelines that NIV is recommended in the acute exacerbation of pulmonary diseases and acute pulmonary edema due to cardiac failure. But the role of NIV in acute hypoxemic respiratory failure and ARDS is debated. This is actually the first study that was conducted in Rome in 1998, and it was published in the New England Journal of Medicine by Massimo Antonelli and Giorgio Conti. And for the first time, they tried to assess whether the NIV could be an alternative to controlled invasive mechanical ventilation. And you see here that 64 patients were randomized to receive either invasive mechanical ventilation in the right panel or non-invasive ventilation with a face mask. And this study was very interesting because for the first time it was shown that NIV could improve oxygenation, you see the PF ratio, to the same extent as compared to invasive mechanical ventilation. And this was obviously associated to the advantage of averting intubation in patients with NIV, namely a reduction in the complications during the intensive care unit stay. However, following studies in the early 2000 did not confirm this data and highlighted an important issue. And this involves the possibility that patients who fail and are intubated after NIV are burdened by a higher risk of mortality as compared to those that are intubated earlier. And this is typical of acute hypoxemic respiratory failure and ARDS. It does not involve COPD or acute pulmonary edema. This highlights the important issue in hypoxemic patients, so also include COVID-19, in which any kind of non-invasive respiratory support, so NIV, CPAP, or high-flow oxygen, are a double-edged sword. In one hand, capable of averting intubation and the need for invasive ventilation. On the other hand, for patients who fail the treatment, these patients are burdened by a higher mortality. So this is very important because it highlights the importance of choosing the proper treatment and monitoring the patient during the treatment. With the final aim of improving the success rate of the non-invasive support and limit the damage provided by delayed intubation to mortality. And we should always ask ourselves which is the physiological rationale for the events that we are seeing in randomized and large-scale trials. And the big issue with acute hypoxemic respiratory failure is that these patients may show a dysregulated respiratory effort. And I will introduce some physiological concepts which are part of the rationale for using one technique or the other in hypoxemic patients. One of these physiological parameters is the transpulmonary pressure. So we all know that when we breathe, the total pressure that is applied to the lungs is the pressure that is produced by the inspiratory muscles. And in case we use non-invasive ventilation or invasive ventilation with pressure support, the amount of pressure that is applied to the lungs is the sum of the inspiratory effort of the patient and the pressure support that we apply on the ventilator. And this pressure is called the transpulmonary pressure and is among the responsibles for ventilator-induced lung injury and patient self-inflicted lung injury. And you see here that in normal patient, in healthy subjects, this inspiratory effort can be -5 to -3 to -1, but it's not so high, so that if we apply 10 centimeters of water of pressure support, we have a total pressure acting on the system of 15 centimeters of water. But in patients with lung injury, the inspiratory effort can be increased by several mechanisms and can reach very high values. This is an example of an inspiratory effort of -20. And if you add some pressure support on this inspiratory effort, which is not relieved, you will have a total transpulmonary pressure acting on the lungs of 30 centimeters of water. This transpulmonary pressure is something very similar to, it's not properly the driving pressure, but it's something very similar to the driving pressure. And it is clear here that if you apply non-invasive respiratory support to this patient, you will only achieve an increased likelihood of ventilator-induced lung injury and lung damage due to the applied ventilation. Unfortunately, the inspiratory effort is not conventionally measured and monitored in ICU patients. We start to and it can be measured with the esophageal pressure, which is not a very common monitoring tool. But when we apply non-invasive respiratory support in hypoxemic patients, we always have to consider the possibility that a strong inspiratory effort is hidden and cannot be measured, but can be present in these patients. And in this case, the application of non-invasive respiratory support can be harmful and can damage the patient. When we have an intense inspiratory effort, I think you mentioned this study in your presentation, this can result in increased tidal volume, because if you breathe more intensively, the tidal volume can be high. In this study, conducted by Guillaume Carteau and the group from Paris, patients who received NIV due to acute hypoxemic respiratory failure were monitored through the face mask NIV, so it's not helmet because it's not possible to measure the tidal volume with the helmet interface, were monitored according to the tidal volume that was produced during the non-invasive ventilation in the early phase of ARDS. And you see here, patients were classified according to whether the tidal volume was greater or lower than 9.5 milliliters per kilo of predicted body weight. This was the median of the cohort. And you see that circles are patients who had a higher tidal volume during NIV, and squares were those who had a lower tidal volume. And you clearly see that the likelihood of treatment failure was much higher, up to 80%, in patients who were exhibiting a higher tidal volume during NIV with a face mask. There is another issue with a strong inspiratory effort, and this regards the possibility that strong inspiratory effort favors the development of a negative pressure pulmonary edema. It is obvious that the equilibrium that is present in the lungs also depends on the relationship between the hydrostatic pressures that harbor in the system. And when patients undergo controlled mechanical ventilation, for instance, they have a pleural pressure which is positive. The capillary pressure, so the wedge pressure, can be a bit more positive. And in this case, you see this example, the pressure that forces the water outside the capillaries is the capillary pressure minus the pleural pressure. So in this case, it is 2. When we have a strong inspiratory effort, and again, I remind you that it's not conventionally measured, and it's very often hidden in our patients that we are treating in the ICU. In this case, the negative pleural pressure favors the passage of water from the endovascular system to the interstitial space. And this can worsen lung injury by activating the hydrostatic edema. And this creates a vicious circle which yields to an increased risk of lower compliance, increased inspiratory effort, worsen hypoxemia. We tried to summarize this in a publication in the Intensive Care Medicine last year. And you see that all these mechanisms which favors the worsening of lung injury during spontaneous breathing in patients with acute hypoxemic respiratory failure are summarized in the concept of patient self-inflicted lung injury, or silly that you mentioned in your presentation. So when we think about the non-invasive support in hypoxemic patients, we always think we need to think to a fine-tuned balance between the capability of improving hypoxemia with our support and the possibility that the patient develops a self-inflicted lung injury due to intense inspiratory effort, higher tidal volumes, increased risk of hydrostatic pulmonary edema. And in this sense, in the last decade, a new tool for respiratory support, which is not properly only oxygen therapy, but a more complex system, is the high-flow nasal oxygen. And this is very convenient for hypoxemic patients because it allows the delivery of the set fraction of inspired oxygen, so increased FiO2, but also it is possible that it is demonstrated that this system, due to a washout of the dead space of the airways, so the nose and the mouth, reduce the respiratory drive and the inspiratory effort, and can improve respiratory mechanics and provide a variable degree of positive airway pressure, which contributes to improve oxygenation. And we all became very familiar with this technique in the last 2 years because it is very simple to use. You need to set just the FiO2 and the temperature of the inspired gas. You set the highest flows, and the benefit to these patients is really remarkable. And in the context of lagging data on the benefit of NIV in hypoxemic patients, with the introduction in clinical practice of a new tool for respiratory support, the group led by the Reva Network, so the French network of mechanical ventilation, in this case led by Jean-Pierre Frat, Arnaud Thiel, René Robert, Roland Brochard, launched a randomized trial that was published in the New England Journal of Medicine in 2015. In this study, 300 patients with PF ratio below 300 were randomized to receive either high-flow nasal oxygen or non-invasive ventilation with a face mask, PIP5, between 5 and 8 and pressure support of about 12 centimeters of water, or standard oxygen through a face mask. The primary endpoint of the study was the rate of endotracheal intubation according to predefined criteria. And you see here that there was no difference in the overall population, but going into the pre-specified subgroup analysis of patients with the most severe hypoxemia, so PF ratio below 200, you see here that high-flow oxygen yielded a reduced rate of endotracheal intubation as compared to NIV and standard oxygen. This is a study that was really criticized because the data seems surprising, but I think that the overall message that can be received from this study is that in case you have high-flow oxygen, adding NIV with a face mask on top of that for sure does not improve the outcome. And in this study, it was shown that NIV with a face mask could even be harmful. So time marched on, and unfortunately, we had to face the COVID-19 pandemic. And this really highlighted the issue of non-invasive respiratory support for hypoxemic patients. Because on one hand, we needed to optimize the non-invasive support because we could not intubate everybody. On the other hand, we had to face the possibility that the support that we were providing could worsen also the outcome. And I mention here a very important, one of the first reports from China, in which patients were treated with the high flow, and they showed that actually patients with a higher PF ratio, so PF ratio above 200, had a risk of failure of 0%. So the possibility that patients that have a PF ratio failed above 200, they failed the treatment, is quite low. While this possibility gets higher when the PF ratio goes below 200. And this is consistent with data that we had from previous studies on hypoxemic respiratory failure caused by other etiologies, in which really the patient who seemed most delicate were those who had the PF ratio below 200. This takes me to the first clinical message. I think that any form of respiratory support is safe and effective in case of mild to moderate hypoxemia, let's say above 200 or 150, while it may really be dangerous and should be used with great caution in patients with a PF ratio below 150. However, we have learned that non-invasive ventilation cannot be delivered solely with a face mask. There are other tools, and one of the other tools is the NIV provided with the helmet interface. The helmet is a transparent hood that covers the entire face of the patient. And in this milestone study by Bhakti Patel, John Kress, and the group of Chicago, patients with ARDS were randomized to receive NIV either with the helmet or with a face mask. So not very controlled settings, but still the first randomized trial that was conducted with the helmet interface. And you see here that really the rate of endotracheal intubation was much lower with the helmet interface. Going into details on the mechanisms for which the helmet could perform better than face mask in these patients, looking at the settings, what really comes up to our eyes and interpretation is that the amount of PEEP that is provided with the helmet, at least in this study, was much higher than that was provided with the face mask. And importantly, in that study, the protocol foresaw a titration protocol for PEEP, which was similar for both groups, but the increase in PEEP in the face mask group was not possible due to the presence of intolerance and leaks in the interface. So I think the helmet could be a useful tool, not due to the helmet per se, but rather because of the settings that this interface permits. And these data were actually accompanied by other data by Takeshi Yoshida and the large group of investigators who are dealing with the role of spontaneous breathing in patients with ARDS and acute hypoxemic respiratory failure. And they conducted a series of studies to assess the risk and the possibility that self-inflicted lung injury occurs on these patients. And in this study, published in the Blue Journal in 2018, they actually shown that PEEP has the capability, so high PEEP, in this case, you see a jump after 30 seconds from 5 to 15. So this increase in PEEP is capable of reducing the inspiratory effort of the patient. In this slide, you see the airway pressure over time, the esophageal pressure, so the inspiratory effort over time, This inspiratory effort is the negative deflection of the esophageal pressure in the figure in the bottom of the slide. And you see here that for ER and pressure support, and if you go from 5 to 15 of PEEP, this is immediately accompanied by reduction in the inspiratory effort. And you see here, most importantly, high PEEP can reduce the tidal volume, reduce the driving transpulmonary pressure, reduce the negative deflection in esophageal pressure, which is the inspiratory effort. And most importantly, if you assess the risk of inflammation in the dependent part of the lung after 6 hours of ventilation with high PEEP or low PEEP, you see that the risk of increasing inflammation, so self-inflicted lung injury in the dorsal part of the lung, is much higher with low PEEP than with high PEEP. So this is a rationale to really assess the comparison between the newer tools for non-invasive respiratory support, which is the high-flow oxygen or the helmet NIV. And we started with a physiological study that we published a couple of years ago, in which we tested the effect of helmet NIV as compared to high-flow nasal oxygen in patients with acute hypoxemic respiratory failure. And you clearly see that helmet NIV can, with specific settings, so high PEEP, let's say 12 centimeters of water between 10 and 12, and low pressure support that is used to wash out the interface and unload the respiratory muscles. So it is not CPAP, it is pressure support with the helmet. So these settings can improve oxygenation, reduce inspiratory effort, respiratory rate, and dyspnea. So the COVID-19 pandemic started, and all the world, I think, used and applied the high-flow nasal oxygen in a wide variety of situations. This is why we wanted to test in a preliminary study whether the application of helmet NIV in the early phase with the physiological rationale that I mentioned you can improve the outcome of patients with acute hypoxemic respiratory failure. And we designed this study, which was conducted in 4 intensive care units in Italy across a 3-month period. It was designed to include all patients with acute hypoxemic respiratory failure, but it ended up including only patients with COVID-19 due to the surge of the third wave. And what we actually did is just to include the most delicate population, and we randomized these patients to receive either high-flow nasal oxygen alone or helmet NIV for 48 hours, followed by high-flow nasal oxygen for a weaning phase. So I think, again, that settings really were important, because what we demonstrated is that what can be applied with safety is the helmet NIV in the pressure support mode. So it's not CPAP, it's pressure support. And it was set with 10-12 centimeters of water of PEEP, 10-12 centimeters of water of pressure support with a standard ICU ventilator. And we compared this to the best setting of high flow, so 60 liters of flow with the same FiO2. This is a summary of the setting of the vent. You see here the helmet. You have 2 tubes. One is for the inspiratory phase, so the inspiratory limb. The other for the expiratory limb. There is no white piece because there is no need for humidification. and there is the antimicrobial filter in the expiratory limb. And you see here that the standard settings that we had, so the high PEEP, low pressure support, FiO2, flow trigger, cycling off criteria. And you see here the waveforms of the ventilator. The monitor of the ventilator does not permit to monitor the tidal volume. So if you put this setting a very high tidal volume, but this tidal volume is actually dissipated to distend the interface, which is not rigid. And we foresaw objective criteria for intubation that were mutuated from the Florari study, which was the study published in the New England Journal of Medicine by the Reva Network. These are very convenient because they can be used to monitor the patient and provide endotracheal intubation in case of failure. And the primary endpoint of the study was the median respiratory support free days, defined as the amount of days on a 28 basis in which the patient did not receive any kind of advanced respiratory support, including high flow oxygen, NIV, or invasive mechanical ventilation. And the study showed that there was no difference between helmet NIV and high flow oxygen in terms of respiratory support free days on a 28-day basis. But what we found, that we were very surprised to see such a strong signal, is that the helmet NIV was accompanied by a 20% reduction in the rate of endotracheal intubation as compared to high flow nasal oxygen. So you see here 50% endotracheal intubation rate in the high flow oxygen, 30% in the helmet NIV. And what really was consistent with the study that we published in the Blue Journal on the physiological effects of helmet NIV is that the reduction in the rate of endotracheal intubation was driven by a reduction in the incidence of hypoxemia and signs of respiratory muscle fatigue and dyspnea in the patients treated with the helmet NIV. So this paper in the JAMA was actually accompanied by an important editorial written by Lavina Mushi and Jesse Hall, in which they highlighted the really important issue of precision medicine in the intensive care unit and the need to identify patients who must benefit from one treatment or the other. This is why we try to reason about the mechanisms driving the benefit of helmet NIV in patients with hypoxemic respiratory failure. And we thought that the most important mechanism underlying the benefit of helmet NIV was the control of inspiratory effort. But inspiratory effort in patients with hypoxemic respiratory failure is really variable. There are patients who have a high inspiratory effort to dysregulated inspiratory effort, while there are other patients which do not have a dysregulated inspiratory effort. And in one case, so in case of dysregulated respiratory effort, the application of pressure support can reduce the inspiratory effort while maintaining the driving pressure within safety limits. While in case the inspiratory effort is not high, the application of pressure support can end up only in increasing the transpulmonary pressure and the tidal volume. Obviously, we did not have data on the inspiratory effort in the trial, but we reasoned about on the effects of on signals and tools to identify the inspiratory effort in hypoxemic patients. And we thought that CO2 could be a good marker because if CO2 is low in patients with hypoxemic respiratory failure, it is very likely that the inspiratory effort is high and the tidal volume is high. This is why we actually separated patients enrolled in the trial in those who had a normal PCO2 before the randomization. And you see here that actually there was no difference in the rate of endotracheal intubation in case CO2 was actually higher than 35. So this confirms the approach. So if the inspiratory effort is not high, is not increased, and CO2 could be a good marker for, low CO2 could be a good marker for increased inspiratory effort. So in case inspiratory effort is not increased and CO2 is normal, the benefit of eMediQ NIV over high flow oxygen is nil. But if the inspiratory effort is high, and this can be accompanied by a reduction in the PaCO2, well, in these patients, the benefit of eMediQ NIV is huge. And in this case, we had a 50% reduction in the rate of endotracheal intubation due to the application of eMediQ NIV. This is really hypothesis generating. These cannot be considered final data because this is a post-hoc analysis, but still a very strong signal and very consistent with physiology. This leads to my conclusions. So I can say that high flow and eMediQ NIV with a high PEEP represent the most promising techniques for the support of hypoxemic patients in the intensive care unit. That early continuous high PEEP with eMediQ NIV may reduce the need for endotracheal intubation, but these are preliminary data that should be confirmed in prospective studies. We do not have final data on the difference between NIV in the pressure support mode or CPAP, but we know from physiology that maybe what is crucial is the delivery of high PEEP. One last message: monitoring on the patient, not to delay endotracheal intubation, and to provide timely protective ventilation in case of treatment failure. Thank you very much.
Thank you, Domenico, for this excellent lecture. Our audience preparing questions. First of all, I have any. So, if I clearly understood for our audience, can you hear me, Domenico?
Yes.
If I clearly understood, the difference between mask and helmet is the value of PEEP. Is it so? So mask can deliver only low PEEP because of leaks, intolerance, and so on. And helmet can use PEEP much higher. Is it so?
I think we do not have final data to say so, but I think there are different mechanisms driving the difference. I think one is the possibility to deliver high PEEP. The second is a good tolerance of the patient. and this permits really long-term treatments without need for interruptions. I think it is very common in our clinical practice that after 8 to 12 hours of face mask NIV, you need to stop it and provide interruptions, and this yields to the recruitment. So I think there are several mechanisms. One could also be that one of the criticisms to the helmet NIV was that the synchronization of the system is not so perfect. So there is a huge delay in the delivery of pressure. So it's not properly a pressure support, but it is something very asynchronous. This could be dangerous in case we want to unload the patient due to hypercapnia, for instance, but could be very convenient in case of hypoxemia. Because being asynchronous, it means that the pressure that we provide with the ventilator is not added to the inspiratory effort of the patient. So the swing in the transpulmonary pressure, which is the sum of the two, is not so high. The face mask is really a synchronous tool, while the helmet is really asynchronous. And we should not care about synchrony because there is a huge volume inside the hood and the patient can breathe the air inside the helmet. If you think, for instance, to the concept of ineffective triggering, ineffective triggering does not exist in the helmet with pressure support because the patient can breathe the air inside the interface. And in that case, for instance, it is a breath that is in CPAP. It's the same. So I think there are various mechanisms that are not fully elucidated, but all these may contribute to the success of the approach.
Thank you. Do you have some comparative studies concerning respiratory physiology, for example, transpulmonary pressure and so on, comparing mask and helmet in the same PEEP level? Crossover studies in one patient?
We do not have data. Thank you. I can anticipate that we have data on the difference between CPAP and pressure support. And again, what we realized is that the big issue is the inspiratory effort. So I think there is this hidden mechanism in patients with hypoxemic respiratory failure that is not considered in clinical practice because it is really difficult to understand and to measure because we need esophageal pressure, which is not very common. And I think the future will be to assess the individual response based on the physiological parameters. So I fully agree there is no one-size-fits-all answer, but still for the first time, I think in the ARDS we have a strong signal towards the possible benefit of an intervention regarding non-invasive support.
What do you think? We discussed in December with Giuseppe Forti non-traditional Venturi systems and helmets, and he told us that pressure support is bad because of high tidal volume, volumetram, and so on. What do you think? Do you really have some real data concerning that pressure support is worse than CPAP, or not? Or it's only speculation?
We discussed with Giuseppe a few days ago. So we measured tidal volume with the EIT, and I can tell you that there is no difference in the tidal volume between CPAP and NIV. Because the big amount of the big part of the pressure that is produced in CPAP is only the inspiratory effort. While in NIV, you reduce the inspiratory effort and you put on top of that the pressure support. And at the end of the story, the amount of the entity of tidal volume is the same between the two. And what it is really interesting is that the amount of tidal volume is much higher with the high flow as compared to the high flow. So high flow it produces a lower tidal volume than CPAP and NIV.
Excuse me, have you measured it on high flow? It was expired tidal volume, yeah?
It was tidal volume measured with the EIT.
Exhalation.
So
exhalation.
the EIT. So the tomography. Okay. So we tried to establish. So we put the belt for the tomography, and we tried to see whether it is true or not that the helmet can increase the tidal volume. And yes, there is an increase in the tidal volume, but this is similar between CPAP and pressure support.
What do you think concerning lung injury when we compare high flow oxygen and CPAP?
This is a really big question, because the issue is that if you just measure tidal volume, this is higher in CPAP. But if you measure tidal volume normalized to the end expiratory lung volume that we did with this belt, so this is a kind of strain.
Yeah.
The end expiratory lung volume is increased by PEEP, and at the end of the story, the ratio is reduced with the helmet. So it is really complex, and we are submitting this paper, and I think that there is no final answer on the real parameter that drives the lung injury, whether it is the tidal volume, the strain, the driving pressure, or the inspiratory effort. Maybe it's a combination of all these. And again, I think the big issue is to personalize treatments, and I think that we have a long way ahead to understand this. So if I have to provide a clinical message, is that you can apply one of the two, but the real issue is to monitor the patient and try to identify the treatment failure. But I fully agree with Giuseppe that there are some patients in which helmet NIV can be worse and CPAP can be better, but for sure there are others in which the NIV can be better and CPAP can be worse. And I think that the critical parameter for defining this is the inspiratory effort.
Giuseppe told us, taught us that don't use helmet with ICU ventilator. Only Venturi system or high flow, one limb, and high flow in the helmet, up to 100 liters. What do you think? You use in your study ordinary circuit, B tubes, ICU ventilator, and so on. What's your comment?
So, Giuseppe suggests CPAP. What we tested is NIV. And yeah. I can tell you that right today, we started a large randomized trial conducted in 40 centers in Italy to compare the two with the high flow. So I think we don't have final data.
To compare what, sorry?
So we launched a trial today with Giuseppe. We discussed with Giuseppe, so he's participating in the steering committee. So one arm is receiving the high flow alone. One arm is receiving the CPAP with the Venturi system or the high flow system. So continuous gas flow and the PEEP valve as suggested by Giuseppe. And one arm is receiving pressure support with the helmet, so 12 PEEP and 10.
With conventional ICU ventilator, yeah?
Yes, like I showed in the slide JAMA. In the JAMA paper. So we will see whether maybe one or the two is better. I think we need data to respond to this. But we also need data to make the helmet more used abroad, because it's really a typically Italian intervention. And because there are no final data, and we are taking the responsibility to provide something.
Thank you. And we're going back to your phenotypes, POCO2, 35 and more. Please imagine that you have high inspiratory effort, not low, high inspiratory effort, and PCO2 more than 35. You don't have these patients in your phenotypes. What's your comment?
What do you mean?
You told us, if I clearly understood, that patient with low PCO2 had more lung injury due to high tidal volume, high effort, yeah, high effort, high drive, high. And patients with normal PCO2 had normal drive and less lung injury. When we talk about patients with high drive and high PCO2, we don't see this in your phenotypes. What's your comment?
So I think this, unfortunately I cannot answer to this, because this is something that we defined a posteriori. So this is something that we inferred, that the higher the CO2, the lower the CO2, the more intense the inspiratory effort. This is very physiologically sound, but it's not, it's actually undemonstrated. So because if you have low CO2 in hypoxemic respiratory failure, I think it means that you have a tidal volume that is greater than the one you need. So it is likely that you have intense inspiratory effort. If you have a normal CO2, it means that the inspiratory effort is not so dysregulated. It's like tailored to satisfy the needs of the body. So we do not say it is more severe or less severe in that study. We just show that perhaps the effect of interventions can be actually different among the different phenotypes of patients. So I don't have data to show that those are more or less severe. We have preliminary data showing that it is possible that the rate of failure is higher with the lower CO2, but in case the patients are treated with the high flow. For instance, if patients are treated with the helmet, there is no difference between high and low CO2 in terms of treatment failure. So again, this is very preliminary and hypothesis generating and provocative in a way, and we clearly need more and large scale data to confirm it.
In our practice, in our clinical studies, which is submitted now, when we talk about NIV failure, we talk about high alveolar dead space. That means higher PCO2, not lower. And for me, your publication was just mixing my results and all mixed up in my head. So what do you think about high alveolar dead space in these patients?
I think that I definitely agree with you. So dead space is an issue. Patients with ARDS have increased dead space due essentially thrombosis in the microcapillaries and wasted ventilation. But there are, I think, two mechanisms that are mixing together. One is the increased respiratory drive, lowering the CO2, and the other is the higher dead space increasing the CO2. So I think that at the end of the story, if you have a very strong inspiratory effort, the CO2 will end up being quite low. And this is what we really see in clinical practice. It's very common to see patients with 30 or 28 of CO2. I definitely agree with you that the issue are combining the increased respiratory drive and the increased dead space together warrants investigations to clarify.
So what was your real criteria for intubation? Time, ROX index, intolerance, PF ratio, what 1 to 3? Can you clinically, not
Clinically,
not so complicated.
No, not so complicated. The criteria for intubation that we applied are the ones that we show. I can show it to you.
Time. Was it time of non-invasive ventilation or not?
So these are the criteria that we used. So one or very simple criteria used in the clinical
I see
practice.
the first criteria, but I don't see time interval here. Unchanged
the time interval is
dyspnea.
here.
What was the time?
The time interval is here, and you see here that it was essentially 1 day and a half in both groups. 1 day.
1, 2, 3 days, 65 hours, yeah?
Yeah, and what we really found interesting is that we applied the same criteria for intubation as in the previous studies published, for instance, in the New England Journal of Medicine on flow, and the time to failure was exactly the same.
For example, we have patient who has good tolerance, 7 days, 10 days non-invasive CPAP ventilation, PF ratio 120, ROX index 6. Do you think that he tolerated good, no work of accessory respiratory muscles? Do you think he need intubation or not?
I don't know.
It's a good answer for the audience.
Yes, this is a honest answer, and I really do not know.
Do you think such patients, 75 years old, too many diseases, frailty, high frailty and so on, and 10 days of NIV, and you know that if you intubate this patient, the outcome will be worse? What do you think?
This is a different concept. It is NIV to support the patient in case the decision not to intubate exists, and I'm definitely fine with this. We don't have, I think, systematic data. We are working on that, and can tell you that in a cohort of 300 patients treated with a do not intubate order, often older than 80 years old, use of a helmet can be associated to a failure of 60%, but still there is a margin for the treatment. But in case you do not want to intubate, I think that any treatment is good, provided that you ensure the adequate comfort to the patient. This is my opinion.
How often did you switch helmet to mask? Due to intolerance? From helmet to mask, or from mask to helmet maybe? Interesting, from helmet to mask, due to intolerance of helmet.
It's very uncommon that we have intolerance to the helmet. It's much more common to have intolerance to the face mask, NIV. Sometimes the patients maybe are supported with some drugs. For instance, I think dexmedetomidine is very good. I think one clear indication to switch from the helmet to the face mask is the hypercapnia. So it's not so common, but it can occur. In that case, it's needed to switch to a face mask with pressure support.
Maybe you should switch to Venturi system with high flow to remove CO2, to wash out.
You mean the high flow nasal oxygen?
Yeah, high flow oxygen and helmet. Change the circuit from B tube to one tube and incorporate it in ventilator high flow.
I think that in case you have hypercapnia, you need pressure support.
I see.
There is no doubt on this. And it is much better to put pressure support with a mask, because you need to unload respiratory muscles. So I think that hypercapnia, we have to keep in mind that we have a clear recommendation from guidelines and randomized studies on the efficacy of face mask NIV, and I will go with that without doubts.
Have you measured PCO2 in helmet in your patients?
We tried a couple of times, but not in clinical practice and not systematically.
I think that I want you to told us about last study in Blue Journal, last paper with Marco Ranieri.
Yes.
You are also, I think you are familiar with it, yeah? Your connection is not stable.
Yes.
Sorry, your connection is not stable.
I'm sorry?
Your video is not stable. Maybe you should turn off your video now, no? Okay. Thank you. What do you think? What is the cause of such a difference in mortality between intubation, which was far worse, and non-intubated patients in this paper?
I think that difference was expected. The real issue here is that actually patients with the high flow have a clinical outcome that it's not so different from those treated with NIV. So when we speak about ARDS, it is possible that also patients in the high flow should be included in this definition. And I think it is expected that patients who are not intubated have a very good clinical outcome, while those that are intubated have a worse clinical outcome.
Why? It was some...
Because they are more severe.
More severe. But
Yes.
I can see it in the paper. The differences between intubated and non-intubated patients. I missed it maybe.
No, I think it is not included, but I think that went really beyond the purpose of the paper, which was really to understand whether the outcome of patients treated with the high flow could be compared with the outcome of patients treated with the NIV. We can calculate, I think it is possible to calculate from the tables, and it should range about 50-60%, which is absolutely consistent with the literature on the topic for intubated patients after a trial of non-invasive support. For sure, what we show is that the mortality is a bit lower in patients with the high flow, but for the same PF ratio, but it is possible that we have an effect of PEEP on the PF ratio. So for the same patient, putting a higher PEEP improves PF ratio, but mortality remains the same.
Was these differences due to extrapulmonary problems, shock, and so on?
I don't think that we went in details on the causes of mortality.
No,
but
yeah.
You know that at the end of the story, all ARDS patients end up dying due to the systemic effect of mechanical ventilation, ventilator-induced lung injury, and shock, and so on. So it is would not be surprising that an increased rate of mortality can be justified by an increased rate of shock, like we have seen, for instance, in the Florali study.
I have a question concerning high flow oxygen. Do you think that high flow oxygen deliver accurate FiO2?
I think so. I think that mostly depends on the peak inspiratory flow of the patient. So if the peak inspiratory flow is very high, then the FiO2 can be a bit lower. But in general, when we compare to the other systems for oxygen therapy, for sure the high flow oxygen is the one that allows the most accurate delivery of the set fraction of inspired oxygen.
Yeah, but if we talk about your paper in JAMA, I see unexpectedly high increase in PF ratio when we switch from oxygen mask to helmet. And in my opinion, at least partially, it can be explained by accurate measurement of FiO2 in ICU ventilator. What do you think?
This is a really good point. This could contribute, at least in part, from Venturi to helmet. But you know that Venturi systems have quite good performance, and they can provide with the mask flows up to 40 to 50 liters with a predefined fraction of inspired oxygen. So for sure that could be a role, but I think that the huge effect on oxygenation mostly depends on the presence of PEEP. And I think we have data on intubated patients to demonstrate that COVID-19 is really peculiar, because the oxygenation response to PEEP is huge in general. And for sure, we are not sure it is beneficial or not, but there is a peculiar aspect of COVID-19 which really regards the improvement of PF ratio due to PEEP.
Okay,
I'm not sure if it's recruitment, reduction in cardiac output, or there are maybe a lot of mechanisms. Some of them could not be beneficial, so I think I would not trust PF ratio when we assess the effect of interventions, unless we have a huge change. But I think the difference that we observed is depends mostly on PEEP. I'm not saying it is good or not. I'm saying that the real cause for the difference is that one.
Do you think that you can differentiate patients? One group non-recruitable or with low recruitability, high flow oxygen, and another group with high recruitability, CPAP. So it will be not comparable groups.
Yes. So you suggest to separate, should use high PEEP in recruitable patients and high flow in non-recruitable patients?
Yeah. So it will be different pathophysiologically patients.
Absolutely, this could have a role. I think that the issue of recruitability mostly involves patients who are under controlled mechanical ventilation, because I think PEEP effects on patients who are paralyzed is only depend on recruitability. In patients who are spontaneously breathing, I think that only part of the effects of PEEP depend on recruitability. there are several other mechanisms that are related to the reduction in the inspiratory effort. So I don't think there are data on recruitability on NIV. This could be really an issue to address. But I think that the mechanism driving the effect of PEEP in non-intubated patients is not only recruitability.
So psylli.
So it's the inspiratory effort, yes.
Psylli.
This is what we putting together, trying to have an overview of the literature. We have a signal about the really important role of the inspiratory effort, as if actually we are used to classify hypoxemic respiratory failure according to the PF ratio. In my interpretation, there are different mechanisms. So one is PF ratio, maybe one is dead space, one is the inspiratory effort, as if there are different degrees of severity according to the different aspects of the disease. But really, this is my interpretation. We don't have data to foster this.
We have some questions from audience. Sergei Popovtsev. Have you ever seen decubitus in helmets? From helmets, so on the neck and so on.
No, because there is the plastic part, and there is no decubitus. There might be something about under the arms if you put the arm prints, but we really barely see the decubitus with the helmet interface.
And what the next question, Pavel Vladimirovich, what is the problem of nutrition in helmet? How do you resolve it? We usually put a feeding tube and we provide enteral nutrition in the early phase of the disease. And after the treatment is discontinued, the patient can eat. The next question. Hello, Mr. Domenico, grazie per questo incontro. I don't know what is it, sorry. Thank you for having a talk to us today. According to some of your publications, helmet CPAP therapy has many beneficial effects over face mask. What would you say of helmet CPAP therapy in the patients with obesity?
With, sorry?
Obesity.
Okay, this is another aspect. This is really important because obesity is becoming a wider problem. And I think that there are few physiological data on this. The data that we are poor. And I think that obesity is another factor that could drive the benefit of IPEEP to reduce the incidence of atelectasis due to the increased esophageal pressure and the lower transpulmonary pressure. So this is an issue that could be really assessed, yes. For instance, we have seen there is a nice publication, I think last month in the Blue Journal, about the fact that most of the benefit of NIV in the post-extubation phase compared to the high-flow oxygen is highlighted in the patients who are obese. So I think that this is an important factor to take into account when we are choosing the interventions to personalize treatments. And if I have to tell you whether or not there is a final study or a clearly study on hypoxemic respiratory failure dealing with this I don't think, I'm not aware of any robust data to suggest, but I think there's a robust physiological rationale that the patient with obesity may benefit from higher PEEP with CPAP or NIV.
The next question: do you think that prone position is beneficial in the non-intubated COVID patients?
We have data, yes, it is beneficial, at least with the airflow. And we have a large trial, putting together more trials, and we saw that there is a benefit on the rate of intubation. Whether the combination of prone position and helmet can be applied with a proved clinical outcome, there is no data on this. There are some data showing that it is feasible from Giuseppe Foti, but no final data for comparison.
Is it possible to reduce tidal volume and inspiratory effort using sedation, propofol, opioids, dexmedetomidine, and so on?
So this is another important issue. Let's say that there are some physiologic studies to address this issue, and the idea is that the response is highly variable from patient to patient. In general, the opioids reduce the respiratory rate, but could be a false friend because they can end up increasing the inspiratory effort and the tidal volume. Dexmedetomidine should have no effects on the respiratory pattern, but it may reduce respiratory rate because it limits agitation. While propofol could be an intervention that can reduce the tidal volume according to the data that we have in intubated patients, but it is really difficult to use the propofol in non-intubated patients. So this is another issue to address in future studies, but for now I think that the aim of sedation could be improvement of tolerance, and it is really difficult to imagine to use it, at least now, to reduce the tidal volume.
Do you know studies concerning opioids or sedation, non-invasive ventilation in COVID-19 patients? Comparative studies which showed us that sedation is better than without sedation?
I'm not aware of any study. There is a large, I think it was a kind of individual data meta-analysis in hypoxemic patients undergoing non-invasive ventilation, published in Intensive Care Medicine 3 or 4 years ago, showing that for sure sedation does not improve the clinical outcome of NIV, but if you use 2 or more drugs together, the clinical outcome is worsened. I'm not sure whether it is a causative mechanism or just association between a more severe patients and a need for sedation, but still, once we need to use high-dose sedative agents, we need to ask ourselves whether the patient needs intubation or not.
Okay. And the next question, delirium and helmet. How can we apply helmet in delirium patients? Is it possible?
It is difficult. You can provide some sedation, as said, with caution, but there might be intolerance, and in that case, the only way is to stop it.
I see. So do you really have such patients in your practice, delirium and helmet?
It's not very common in our practice, especially in patients who have COVID-19 in the early phase that are fully awake. But it can happen, and in that case, we can provide some sedation. But in case this does not work, we provide endotracheal intubation very early.
And can you switch such patient to high flow or not?
Yes, this could be a good solution because comfort is much better with the high flow.
So when we talk about elderly patients with agitation, bad tolerance of helmet, can we switch it to high flow? Yeah?
Absolutely, yes. I think that the future is that these two tools are not one or the other, but they can be put together. The best balance is not clear yet, but for sure the comfort is much improved with the high flow.
One provocative question: can we compare high flow? Not compare. Include high flow in a helmet. So wash out dead space and CPAP with helmet combination.
This has been done by Tommaso Mauri and Paolo Navalesi. There are a couple of studies, one in the Blue Journal, one on respiratory care. This could be a really big, nice solution, but I think that we need confirmatory studies on the clinical outcome before saying that this could be a solution applied in clinical practice.
So we do not have any studies concerning COVID-19 now, comparative, no?
Not in my mind.
I see. So, Domenico, I'm totally exhausted. I have no questions, and our audience too. Thank you for joining us.
It's been a pleasure. Thank you for inviting.
I think that for next time you will invite you and you give us the consent to participate.
Absolutely, yes, with big pleasure. Thank you very much.
Thank you. Thank you. See you.
Stay safe. Bye-bye.
Bye. Bye.
Thank you very much.
Thank you. Bye.